talk on the strain imaging. So I welcome Dr. Sundaram. So he's going to talk on the role of echocardiography in strain imaging. I think mainly, and I can like highlight the importance of the where you'll feel that MRI will be superior to the echocardiography, and what are all the limitations of the echocardiography in strain imaging. Yeah, maybe you can highlight that point.
Am I audible? Yeah. First of all, let me thank the organizers for giving me an opportunity to be a part of this program. So, yeah, as you know, like one of the important job which is kept in front of echo is to get an estimate of left ventricular systolic function. Obviously, we do have other chambers and valves to be assessed, but the main task in front of echo is to get an estimate of LV, ejection fraction, or systolic function. So it obviously ejection fraction is a time-tested method of estimation of LV systolic function, but there are limitations for this method as well. It provides an indirect estimate of myocardial contractile function, and it is obviously readily influenced by various factors like preload, afterload, heart rate, and all those stuff. It is not really sensitive enough to detect subtle changes in the contractile function. So when there is a search for an appropriate method of assessment of left ventricular systolic function, there comes the role of strain imaging, which is basically otherwise called as myocardial deformation imaging, which is supposed to be directly quantifying the extent of myocardial contraction, and it provides estimate of myocardial integrity as well. So before going to the advantages and disadvantages of echo and strain imaging, what is really strain? It is a measure of myocardial deformation, as it is mentioned here. This is the myofibril length at the end of systole and at the end of diastole. So strain is basically calculated by the subtraction of end diastolic fiber length from the end systolic fiber length. So we get a negative numerator divided by our end diastolic fiber length. So when there is myocardial shortening during systole, we get a negative value for strain, and when there is lengthening either during systole or diastole, we get a positive value for strain. As you know, the myofiber arrangements in the myocardium is not in the single direction. It is longitudinal, circumferential. So the myocardial deformation during systole and diastole is a multidimensional process. So in order to capture that, we have various forms of strain, longitudinal, circumferential, and radial strain, as it is there in the cardiac MR also. So to begin with, it was all calculated with the tissue Doppler based, but since it was filled with a lot of disadvantages, now we are moving on to the speckle tracking based strain. So I'll just quickly go through what are all these speckles. These are produced by every group of myofibril reflects the ultrasound in its different manner. So we get a signature pattern for a specific area. So we can identify the speckle and track the speckle during various phases of cardiac cycle. So during systole, it can move from one place to another place. So with a complex algorithm, we calculate strain from the location of this, tracking this speckles. So what is really important, like this is being an ultrasound imaging modality, what is really important is the inter-individual variability in testing and getting a number is really high. So in order to standardize the measurement, we need to get a good image. So optimal image acquisition is very important, more than the number what we have. So I'll just quickly go through why the image quality is important and how to acquire an optimal image. So like the optimal high quality 2D image from apical 4-chamber, 2-chamber, and long axis. Depth has to be reduced in order to focus left ventricle. Apical foreshortening is one of the common mistake being done to get a good image, so that has to be avoided, and we need to get a good frame rate. ECG gating is a mandatory because many of the echoes are being done without ECG, so strain imaging is not possible without ECG gating. And and identical heart rate. I mean, when there is significant RR variation like atrial fibrillation or any other arrhythmia, the strain calculation is going to be difficult. And we need to get at least 3 cardiac cycles to be recorded so that we get one good complete cardiac cycle for recording. And breath hold is uh, encouraged so that we avoid breathing artifacts. And slightly overgained image are needed to get a good speckles. So as you know, this is our calculation of strain is depending upon the good 2D image quality. So if you have a 2D image like this, as it is seen here, your strain calculation is not going to be dependable. We are not supposed to calculate strain with this kind of images. So many of the cases we do come across a suboptimal image quality where we might have to choose some other imaging modality like cardiac MR for calculating strain if it is really mandatory. And next to the image quality, the placement of ROE and placement of all this positions needs to be looked at before interpreting the numbers. So like here in this image, you can see that the ROE is crossing the annulus going into the atrium. Obviously, it is not appropriate. The right-sided one is more appropriate placement. In the same way, in apical long axis view, here the ROE is extending into the aortic root. Obviously, that has to be avoided. It has to stop short of the aortic root here. And again, thickness of the region of interest. So it shouldn't be too thick to include the pericardium where the strain values are going to be spuriously low, and it has to be just including only the myocardium. And it shouldn't be too thin either, where it will just include only the endocardial strain, which is going to be higher than that of the transmural strain. The same way, some of the confounding structures which can mislead us, the hypertrophied papillary muscle, we should avoid that, and we should go to relay to the LV myocardium as such. So, having got a decent image and appropriate ROE placement, obviously here comes the various display methods for this strain. If you see, we have segmental strain curves. As you know, the American College of Cardiology and IACI divides the myocardial segments into 16 for echo, and the perfusion methods it is 17. So we have segments here represented in all these 3 apical views, which are represented here in the segmental strain curves. The average strain values are obtained. The average one is depicted in the white dot, and segmental values are depicted in the colors. And the other display method is the parametric imaging, parametric method of displaying, that's like something like color mode, where if you see a single red carpet right here in the middle, it's going to be normal. And if there is any abnormality, as it is seen here in this diagram, it is going to be abnormal. And the other method of display again is the bullseye, that is the peak systolic LV strain are represented here. All the segments are represented here. The basal segments are in the outer ring, and the apical segments are in the inner ring. So when the strain, the color is something like this, red dark, it is going to be fairly normal. So the color coded bar chart is right here. Yeah, I mean, the other display, other parameters which can be assessed are the time to peak. I don't want to go in detail. So this is about the electromechanical dispersion, the electromechanical delay. So from the onset of QRS, the peak systolic dispersion, what time is it taking, is displayed here. So this is one important marker of arrhythmogenicity of the myocardium. When there is significant dispersion, there is electromechanical dispersion. The likelihood of arrhythmias are going to be high. The cutoff given us more than 60. And this is post-systolic index. I'm not going in detail with that. So the normal values, as far as the global, that is the average peak systolic longitudinal strain, is between -16 to -18. So if it is more than -18, more negative than -18, it is clearly normal, and less negative than -16 is going to be abnormal. So as I told you, like the important thing is to how we got that number is really important, and the optimal image and optimal placement of ROI are important before interpreting the numbers. So coming to the clinical applications, this is from Tom Mowick, which was published in 2018. So these are all the various applications. I'll just briefly go through all this. So to begin with, in heart failure, As you know, like the role of ejection fraction in prognostication as well as diagnosis is really doubtful when the ejection fraction is above 35 to 40%, where the value of strain really is preserved. So in heart failure with mid-range ejection fraction where the EF is more than 40%, and preserved ejection fraction where the EF is more than 50%, it is useful both for prognosis as well as diagnosis. But when, as far as the ejection less than 40% reduced ejection fraction is concerned, it is not really useful for the diagnosis. So that's what it is. So, like as far as the diagnostic algorithm of heart failure preserved ejection fraction is concerned, this is from European Society of Cardiology diagnostic algorithm, where the strain really plays a role. When the strain value is less negative than that of minus 16, obviously it carries a point in the diagnostic marker. As I told you earlier, this is the myocardial dispersion as such. The electromechanical dispersion, where if you see the peak systolic contraction is happening at various time intervals. When the peak systolic dispersion value is more than 60, it just indicates that the arrhythmogenicity of the myocardium is significant. And strain has a role in identifying the ideal CRT candidate. I'm not going in detail about the numbers. So the longitudinal strain values, that is pre-stretch and during rebound stretch, all these numbers are important in identifying the ideal candidate for CRT as such. So the mechanical dysynchrony, which is going to be useful for CRT, and electrical dysynchrony, that is electromechanical dysynchrony, is going to be helpful in ICD. So GLS aids in classification of heart failure subtype, especially if the ejection fraction is more than 35%, and mechanical dispersion, and identifying electromechanical delay for the CRT candidacy. And GLS, when it is less negative than 6.9, associated with higher risk regardless of ejection fraction. I'll just quickly go through some of the utility in cardiomyopathies. So, like as we discussed in CMR, strain is helpful in identifying the differentiating this from the hypertensive heart disease, where in hypertrophic cardiomyopathy the values are more negative than that of hypertensive heart disease as such. And sigmoid septum, which is a common finding in echocardiography, especially in elderly and hypertensives, where the strain values, if it is really low, it can direct towards the hypertrophic cardiomyopathy than the sigmoid septum in elderly. And again, the pattern recognition, which is like in bullseye map, where if you could see the apical segments have really decreased strain, where you can think about apical hypertrophic cardiomyopathy. And when like it is useful in prognostication as well, we can use strain numbers as a binary number when it is less negative than 16, where the outcome is going to be poor. And differentiating LV non-compaction from other hypertrabeculations, when the GLS is going to be really less, it is more likely to be non-compaction than hypertrabeculation as such, as it is shown here. And amyloid, we have various parameters to suggest cardiac amyloid. One of the common finding what we see in amyloid is the apical sparing pattern, though it is not the earlier finding, where the segments have preserved the strain values than basal and mid segments. We have a lot of objective way of quantifying this as well. So the pattern identification is useful in cardiac amyloid as well. So when the GLS is less negative than minus 15, and the relative apical sparing, as it is shown in the previous case, it is an important marker pointing towards that. I'll just quickly go through a few slides. It is useful in cardiac sarcoid as well. Where it is more useful is when the ejection fraction is normal and ECG is normal. With a proven cardiac sarcoid, if you want to really, proven extra cardiac sarcoid, if you want to see whether the patient has cardiac involvement as well, GLS has a role. So it is useful in differentiation as well as prognostication of various cardiomyopathies, and discerning various forms of hypertrophies like hypertrophic cardiomyopathy, whether it is hypertrabeculation versus LV non-compaction strain is going to be useful. One of the area where strain is really useful, proven useful in therapeutic as well, is chemotherapy-related cardiac dysfunction. The various chemotherapeutic agents are obviously cardiotoxic. So to identify early, I'll just keep this case. to identify early and act early, the strain is useful. This is the ESC guidelines which is published recently, where there is, though there is the ejection fraction is preserved, but if there is a relative reduction of GLS by 15% from the baseline, suggests that it is an early cardiac damage. So we can obviously start the patient on drugs like ACE inhibitors and beta blockers before the patient develops clinical heart failure. So this is how it is. So we can start these drugs so that the patient had a better outcome. So preclinical involvement in hypertension, diabetes, and obesity again can be identified with reduced strain values, though ejection fraction is normal. And in valvular heart disease, I'll just,
Sundaram, can you sum up?
yes, I'll just. So like it is useful in valvular heart disease, though the ejection fraction is preserved. When the GLS is less negative, the outcome after surgery is going to be poor. The same way in patients with aortic regurgitation, where it is less negative than minus 19.5, the outcome is going to be poor. And even in mitral regurgitation, if it is less negative than minus 20, the outcome is going to be poor. So, so to conclude, the strain is useful for prognostication and diagnosis of heart failure, and it is useful therapeutically also in chemotherapy-related cardiac dysfunction, asymptomatic valvular heart disease, where we can send the patient for surgery or not, differential diagnosis of left ventricular hypertrophy, and also in patients with ischemic LV dysfunction, where we can suggest whether the patient is a candidate for CRT or not. It adds up to the value than the routine echocardiography. Thank you.
Thank you, Dr. Sundaram. Can I call upon Dr. Deepak Patkar sir to facilitate Dr. Sundaram?